Once again, thank you for joining us in this historic Black Health Matters Summit, virtual summit. We're going to talk a little more about prostate cancer. Research tells us that 1 in 6 African American men will be diagnosed with prostate cancer in their lifetime. And African American men, unfortunately, die from prostate cancer at 2.2 times higher rate than men of other races. Joining us is Dr. Lewis Kampel of Memorial Sloan Kettering Hospital. Since 1983, Dr. Kampel has concentrated on prostate cancer, a disease with a disparate impact on African American and Caribbean men. His interest in this problem led to a collaboration with representatives of the government of Jamaica and the Jamaican community in New York, seeking to develop programs that might identify the cause and encourage earlier diagnosis and treatment of prostate cancer in this high-risk group of men. Dr. Lewis Kampel, thank you very much for joining us.
Thank you, Mr. Rock, and I sincerely want to thank the organizers of this program, which is so timely. I want to thank them for including me in the program again. I am truly honored. So, wow, it's been quite a few months since the original scheduled time of this program. We've experienced a devastating viral epidemic that has again disparately and disproportionately affected the poor, the poor and people of color in New York, and more recently, prompted by events in many cities across the country, we've opened up a very serious and sometimes painful discussion on racial injustice and racial equity. And it's important to point out that health inequity is a very important part of that overall discussion. That was articulated by Dr. Martin Luther King in 1966, when he stated, of all the forms of inequality, injustice in health is the most shocking and inhuman. So with that in mind, I want to talk about what we are doing to address the issues of disparities, particularly in prostate cancer at the Ralph Lauren Center. So the Ralph Lauren Center was developed in 2003 with the goal of providing screening, prevention, and treatment services to those who are underserved with the hope of reducing the disparities that I'm going to talk about. As of April of 2019, the Lauren Center became officially part of Memorial Sloan Kettering, giving us access to all the knowledge, expertise, technology, and treatment at the main center, while maintaining a very warm, culturally sensitive environment. And late in 2019, the Breast Examination Center of Harlem, which used to be located in the state office building on 125th Street, moved into our facilities, which allows us to expand our screening programs, including a state-of-the-art mammography machine. So this is just a picture of our waiting room, and this is a map of where we're located. Shown also is our nutritionist interviewing a patient, an important part of our activities. Again, we do screening, prevention, and treatment for most common cancers and blood diseases. So let's talk about prostate cancer. And the important point here is prostate cancer is the most common cancer in men. And if you look at that number, it's almost 165,000 patients a year. It is also the second most common cancer, fatal cancer in men, with about 30,000 people dying a year. So also notice the difference. 165,000 people get it, 30,000 people die, which means that most people, most men with this disease do well. And that is the good news. These are statistics specifically for African-American men. And again, it is the most common cancer and the second most common cancer killer, but the percentages are higher compared to the other slide. But the next slide will make this more clear. So this is the most important and shocking piece of data that I have to show you. I was introduced by the gentleman who commented on this. What this tells you is that if you are African American, you have 1.76 times the chance of getting prostate cancer compared to a white man. So putting it another way, for every 100 white men that get this disease, 176 African American men get this disease. And for every 100 white men who die of this disease, 220 African American men will die. 2.2 times the risk of death. Now, that is an absolutely startling number, and it just cries out for action to reduce that disparity. So how do we reduce disparities in, let me just backtrack. So why is there such a big difference? And the right answer is we don't know. Genetics probably plays a role, and we're now able to actually look at the genes that are in the cancer cell, and we have identified certain genes, cancer-causing genes, that are more common in Black men than in white men. That doesn't mean you necessarily inherit it from your father. It means that that after you're born, normal genes change. It's called a mutation. And when they change, they cause cancer. So we found some, but that's probably only one of many factors. We really don't know much about environmental factors. Diet, we believe that obesity, like for many other cancers, obesity plays a role. High intake of unsaturated fats and carbohydrates all may increase your risk of getting prostate cancer. So we recommend a heart-healthy diet, less red meat, less sweets, more fruit, vegetables, fish, poultry, pork, rather than red meat. Culture, there may be some fear of testing, which delays diagnosis and results in a worse outcome, but we really don't have good data on that. But access to care clearly plays a role, and we have been able to show in research done at the VA hospitals where access is equal, that these disparities narrow. So the short answer to the question posted on this slide is that we really don't know, but probably it's a mix of these factors. Okay. I'm not going to dwell on this because I think maybe other people have talked about it, but the prostate gland is part of the reproductive system. It sits between the bladder and the rectum, and the main tube draining urine from the bladder to the outside passes through the prostate, in addition to fluid during ejaculation. Now, as you can see, it's in a critical spot because if it gets large, it can press on the rectum and cause bowel issues, and it can block the flow of urine, which can cause a variety of symptoms. So I'm going to pass on the common prostate diseases because I think that either has been discussed or will be discussed. Let's just say that there are no specific symptoms for prostate cancer. In fact, early prostate cancer has no symptoms, but very often the symptoms that drive men to care, at which point they're diagnosed with prostate cancer, most of the time those symptoms are related to just routine, common benign enlargement of the prostate that all men get. Okay, risk factors. So what are the risk factors for getting prostate cancer? Well, clearly being born male is probably the most important one. Not much we can do about that. Age is another factor. Most prostate cancer occurs in men over 65, although we do see cases very young, particularly in the African American community. I just saw this month a 42-year-old man who presented with advanced prostate cancer. So yes, it is generally a disease of elderly, but it does occur in younger men and tends to be more aggressive when it occurs in younger men. There's a slight family tendency, but most prostate cancers, as I alluded to earlier, are not inherited. Race, as we just discussed, being born Black, and particularly if you are a Caribbean man of African descent, the risks are even higher than those for African American men. They're extraordinarily high. And again, we don't know why that is. There are certain genetic syndromes that you can inherit. The most common one is called the BRCA2 gene. It was originally thought to be limited to breast and ovarian cancer, but we find that in maybe 10% or so of men with prostate cancer, they have mutations in this gene, which makes them at very high risk of getting prostate cancer and other cancers. So if we want to affect or lower the impact of this disease, reduce those disparities, there are basically three things we can do. We can try to prevent it from happening. If we can't prevent it from happening, we can try to pick it up early. Or if we can't do either of those two, we can offer a high quality state-of-the-art treatment. So I threw up this slide, even though this may be a little bit confusing. The long and short of it here is there are no standard of care preventative treatments. These two drugs were tested, and there was a lot of controversy about whether they helped or not. At the end of the day, it never gained traction and never became standard of care. But here's the point I want to make, that in the trials that looked at prevention with these two drugs, there were very small numbers of African Americans. So it's possible we are missing a beneficial effect in African American men, but we don't know. And I think my colleague, Dr. Carol Brown, is going to be talking about how important it is for more African American people to participate in clinical trials. Because maybe even though it didn't work when you lumped a whole bunch of people together with only a small number of African American men, maybe if we looked at just the African American men, if there were enough of them in the trial, we would find it was beneficial. And I might add the reverse could also be true. You might find a drug that works in the general population, but may not be tolerated well among African American men or women. So it's very important for clinical trials to include a broad spectrum of our population so that we can pick these things up. So as I said, there's other than eating a heart-healthy diet, there's really not much we can do to prevent this from happening, at least at this point. So the next best thing we can do is screen. A screen means trying to pick up these cancers before they spread and when they remain curable. So again, a complicated slide. Let me just summarize this by saying we should screen. The data indicates a benefit, and for high-risk patients, we should screen. We advise African American men screening starting at age 40 and continuing till about age 70, particularly if there's a strong family history. Who should not be screened? Well, the only people that should not be screened are those who are very old or very sick with other conditions. I'm going to talk about PSA screening in a minute, but more precise screening is on the way. We are looking at blood tests that might pick up prostate cancer 10 or 15 years before it develops, allowing us to intervene before it actually develops. But that's on its way, not here yet. Okay, so how do we diagnose prostate cancer? Again, early symptoms, there are none. The digital rectal exam, which is an unpleasant but not really painful examination and one that scares a lot of people away, it's not very accurate. It's useful when someone has a pretty large tumor, but it will not pick up very small cancers. And it's important to remember that it may pick up abnormalities that turn out not to be cancer. So it's not the best test. Most of our screening these days is focused on PSA, prostate-specific antigen. It's a chemical that's made in the prostate gland, and its role is basically to make our swimmers move faster to get to the egg to make a baby. That's That's what the body wants us to do, and that's what PSA is designed to do. But it is detectable in the blood and can be used as a marker. Now, it's important to understand that there is no absolute normal for PSA. So if you look on a chart or you look in a lab report, it'll say something less than 4.5 or less than 4. In reality, that is not specific enough. We look at a number of factors. We look at how old you are. A PSA of 5 in a 70-year-old man is not worrisome at all. A PSA of 5 in a 60-year-old man or a 50-year-old man is very worrisome. So you have to put the PSA number in context, in this case, in context of age. And there are other things we look at. And again, I won't go into a lot of detail on this, but we can tweak the PSA numbers. We can watch how fast it's going up and so on, and come up with a decision based on the PSA whether or not to do a biopsy. It should also be noted that the PSA level can be decreased by certain medications, artificially decreased, so you could get a false negative, and certain things like an ejaculation or a bout of urinary retention, and maybe even bouncing your prostate on a bicycle seat for a couple miles might also increase your PSA. So the PSA is widely used. It's a simple blood test. It's inexpensive. The turnaround time is about 24 hours. And if it's high for your age, then we have to start thinking about biopsies. But I want to mention that this is a changing field, and right now we are also looking at using MRI after PSA and before biopsy, hoping that by MRI we would be able to tell if it looks like there's something bad going on in the prostate and then go ahead with biopsy, which can have some risk with it, or the MRI might tell us, yeah, the PSA is high, but we really don't see anything worrisome, let's watch. So whereas in the past, a high PSA, whatever that was, might automatically or reflexively trigger a biopsy, we are starting to take it a little slower and thinking carefully before we do the biopsy and using a bunch of other techniques that might avoid biopsies that are likely to give us a negative result or likely to give us a result of a very unaggressive cancer that doesn't need to be treated. So what are the treatment options for early prostate cancer? Surgery and radiation. With radiation, we usually give anti-hormone therapy. They're equally effective. No one can say that one is better than the other. We generally like surgery for younger men, healthier men, radiation for older men or men with medical problems that might make surgery more difficult or risky. I also want to make the point, and this is really important, that many prostate cancers we find are not dangerous, they're barely cancerous, and they're not likely to cause any problems to the patient in their life expectancy. So when we make that determination, we try not to treat people because both surgery and radiotherapy do have side effects. They have sexual side effects, they have urinary issues, sometimes bowel issues. So we have to decide, does this cancer, if we find a cancer, do we really need to treat it or not? So active surveillance is a process by which we watch people carefully, watch their PSA, maybe repeat MRIs, maybe repeat biopsies periodically, hoping to either avoid treatment completely because the patient is going to go on to die of some other disease in the next few years, or to defer treatment and protect quality of life as long as possible. Watchful waiting is a little bit different. That's what you do when you find someone who's very, very old and sick, who's probably got a life expectancy of a year or two, bad heart, bad kidneys, bad lungs, et cetera, et cetera, et cetera. And we take the position we take a position of saying, you know what, we're going to ignore this purposely, and if it starts bothering you, we'll start treating you then. But for cure of prostate cancer, surgery and radiation are the mainstays. There is some research about different kinds of focal therapy. Again, it's a developing field, and I say stay tuned. For advanced prostate cancer, for those that are too advanced to be removed surgically or treated by radiotherapy or have already spread, the mainstay of treatment is removing testosterone or lowering testosterone. It involves usually shots, but sometimes pills, to lower the amount of testosterone in the blood. Now, testosterone is the hormone that kicks in at puberty, makes you grow a beard, makes you start thinking about sex. So when you take testosterone away, there are side effects. Weight gain, breast enlargement, loss of sex drive, etc. But it is very effective treatment for people who are sick with prostate cancer. Pain goes away usually. The PSA goes down, tumors shrink, but it is not a cure. And then we sometimes use chemotherapy, increasingly immunotherapy, and we can use radiation applied to painful sites to control pain. So what is the good news? The good news is that the data shows that maybe these disparities that I showed you at the beginning of this talk are narrowing, and that may have something to do with improved access to care, Obamacare in particular, maybe due to increased screening. Another piece of good news is that African-American men seem to do as well, in some cases better, with treatment, particularly with hormone therapy. And again, another area that we really don't know much about. So to sum up, prostate cancer is much more common in African-American men, particularly Caribbean men of African descent. It is much more dangerous in that population. Screening does work. It reduces the risk of dying of prostate cancer by 20%. There's been a lot of controversy about that, and you're going to read articles pro and con. I strongly recommend routine screening by PSA for all African-American men starting at age 40 and going up to about age 70. Treatment options are improving, but the mainstay remains surgery and radiotherapy for curable prostate cancer and hormone therapy, followed by chemotherapy and maybe immunotherapy for people who are not cured. We are entering the era of precision medicine in terms of screening. I alluded to this earlier. That means we might be able to take a blood test, not for PSA, but actually to detect small amounts of prostate cancer DNA in the blood years and years and years before it develops, and that could lead to early intervention and prevention. And for people who have advanced disease, we are now able to sequence the DNA, the gene in the cancer to see what drives that cancer, what is actually making that cell go criminal, behave like a cancer, not a normal cell. And we may have drugs that target that particular gene abnormality that works for the individual patient. So that is where we are with prostate cancer, particularly in the era of precision medicine. I'm going to stop now, and I'm happy to answer any questions. So, all right. So let me go through it. First question, how does a person pick a urologist? How do you pick any doctor? I think if you're working at a hospital and you have heard good things about the doctor, that's not a bad choice. How can you prevent erectile dysfunction as a result of prostate cancer treatments? That's a tough question. I'm not going to paint this as a pretty picture. It is a major complication of surgery. With surgery, it happens pretty quickly. With radiation, it's delayed, but it does happen. There are treatments, medications, injections, and actually penile implants do help a lot of guys. At Memorial Sloan Kettering, we have a team that is devoted to helping men with sexual problems related to cancer, and they do a great job. But I'm not going to lie to you, this is a serious problem. We take it seriously. We treat it as a medical problem, just as we would treat an infection or a blood clot. It is part of the cancer syndrome, and we like to take the whole person into consideration and recognize that it's an important part of life at all ages and that it needs to be addressed. Research is underway. I wish I could be a little more optimistic. It's still a major complication. On the other hand, if you don't treat prostate cancer, the cancer grows and traps the nerves that and blood vessels that are involved with erection and erectile dysfunction results anyway. What strategies to put in place to educate young African Americans under the age of 30? Yeah, that's a good question. So let me repeat it. What strategies should we do to educate men under 30 about the advantage of a lifestyle change in order to curtail the risks of prostate cancer? Excellent question. Look, I think we have to get into both men and women at a young age for a variety of lifestyle changes to reduce their cancer risk and to improve their overall health risk. Healthy eating. Now that could be a challenge in communities where there's food anxiety or food insecurity. It's good healthy food sometimes is not available in poor communities. Good healthy food may be more expensive. So we do have a program at the Lawrence Center to address that. But in addition to healthy eating, exercising to keep weight down, no smoking. God, smoking is the biggest problem we have in terms of cancer cause. It's responsible for many different kinds of cancer. Immunizations, HPV immunization prevents cancers in both women and men. So there are a lot of things we can do. I think we have to get into the schools. I think community groups, churches, social organizations have a big role to play in making those changes. So the question is it better to pick a doctor that's part of a big organization rather than a smaller one? So I have to admit, I'm prejudiced about this. This is my bias. I left the private practice world 26 years ago to join an academic medical center. I have no data to support this, and I'm sure there's excellent medical care at all, anywhere in the community. But if a friend calls me and they say they have a serious medical problem, I always tell them you're better off at a large academic medical center, and there's several in the city. Memorial Sloan Kettering Cancer Center is known for its cancer care, but there are great cancer programs at all the academic centers: NYU, Sinai, Columbia, Lenox Hill. If I miss someone, I don't mean to slight them. I think the issue is that there's much better oversight of professional performance at large organizations. So I think, okay, couple more. I'll keep going until you stop me. Okay, what questions should you ask if you need a prostate biopsy, and what type should you do? So the standard prostate biopsy is a transrectal biopsy, although we're moving more now to MRI-guided biopsy. I think you need to ask the risks, and you need to ask, what is the likelihood that a significant cancer will be found? If you are African American, would you recommend an African American doctor? Why or why not? That's a tough one. I'm going to pass on that. I think you have to find a doctor that you feel you can relate to. I think it's very important, that listens to you, that you feel understands you, that you feel you can have access to, that you feel sensitive and kind. If that happens to be someone of the same race you are, fine. If not, that's fine also. I think we have a shortage of African-American men and women in oncology, and I think that's very important to correct, because I do think it's important that when a patient goes into a medical center, they see people who they can relate to. That's a major deficiency in oncology that we are working to correct. I think I might be getting, at what age should men start getting a PSA test? I would recommend 40 if you're African-American. Okay, so here's an important question. Why is it recommended to stop screening at age 70? The reason for that is that most prostate cancers found at age 70 are not likely to become bothersome, cause symptoms or spread or shorten your life within the next 10 or 15 years. So if you're 70 and you're diagnosed with a low-grade prostate cancer, it's much more likely that you're not going to die of that. You're going to die of whatever else is in the cards, the tea leaves, etc. So we don't recommend it. It's not a financial issue. It's a matter of quality of life, because prostate biopsy does have some risks, particularly if you're older, and then you get sucked into treatment that you might not need. On the other hand, there are some men that present older with bad cancers, so it's a tough call, and I would say we individualize that. So just to wrap up, we do have an exhibition booth with live reps if more information is needed. I think I keep going through the questions. A real important one is patient part of the decision to treat or not treat? Absolutely 100%. The basic principle of medicine is patient autonomy. You have the right to decide what you want to do. All we can do is give you information. We can make recommendations, but it's critical to understand what works for that particular patient. When I see a patient in this situation, it's an hour and a half discussion. I try and get into the patient's head to see what their values are. You know, for some men will say, look, I don't care what you do to me. I just want to live longer and longer. And other men will say, nope, I don't want to live, even if it's 5 years less, if I can't control my urine and I can't have sex. So every patient, every individual has different values, and it is critical for the doctor to understand that and to work with the patient. I'm not going to answer specific questions about, a person asked about specific PSA values. You feel free to contact me offline. You know, if you'd like, you can call me just for an informal question and answer. I'll be glad to answer that. I think there are tons of questions. If we can work out some way of answering them offline, I'm pretty sure I've used up my time. So I'm going to stop unless I get a message that you want me to continue. Okay, thank you very much. It's been a pleasure. I look forward to speaking to this group again. And again, if anyone has questions, please try and maybe send me a message through the group, and I'll try and answer them.